All right. This is Merritt Thorpe doing a training on panic, how to treat panic. I want to start by saying that this was a real revelation to me, learning about panic. I did not learn about this in grad school, and it taught me stuff about my own experience having panic at different points in my life. I think this is an area where we can help our clients see things differently and make some pretty quick gains in our through our treatment. Um, okay, so how do I? Oh, next. All right, click on it like that. Sorry. So panic or panic disorder. So these are the symptoms of panic. Uh, it's an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes. So it's a fast thing, usually quick in and relatively quick out. And these are all, let's see, 1 through 11 are the actual physical symptoms that people might experience. And it is quite a range of physical symptoms. Pretty much anything that you would do in fight, flight, or freeze, you can experience when you're panicking. Or multiple of the symptoms, like they say, 4 or more. But 2 of the symptoms here are fears rather than the actual physical symptoms. So fear of losing control or going crazy, or fear of dying, which, is a real thing. I've talked to clients who have thought there was something really wrong with them. So that's a definition of panic. This is a definition of panic disorder. So a full-blown panic attack plus persistent concern or worry about additional panic attacks or their consequences. So I'm going to, have another panic attack. I'm going to lose control. I'm going to have a heart attack. I'm going to go crazy. And then also a behavioral change. We are changing our behavior to keep from putting ourselves in situations where we have panic. Might avoid exercise, might decide they don't want to go to restaurants, etc. So people who have actual panic disorder not only have panic attacks, they fear their symptoms and they fear their fear. They start changing their life to fit the panic, which we really don't want to do. Exposure therapy or theory teaches us that we don't want to listen to that if we can avoid it. One thing I forgot to say on the earlier slide, if you have fewer than 4 of the physical symptoms, technically that's called a limited symptom attack. It's not really a panic attack, but most people, if you really think about it, do have 4 or more symptoms. Now, is it panic or is it anxiety? I have had multiple clients say to me, my panic attacks last for hours. Well, I'm a little skeptical about that. And this presentation got me to actually look it up. Panic attacks, they're episodic, they're discrete, they're separate from each other. So, somebody might experience multiple panic attacks in sequence, but they're usually distinct. Anxiety is more like an ongoing state of worry and unease. It's not a discrete episode. It is possible to have very high anxiety for long periods of time, but I think part of the way that panic attacks work is that you get this big rush of symptoms and the chemical transmitters that cause that rush of symptoms can only last for so long. Okay, so it is going to pass. So panic attack distinguished from ongoing anxiety by its time to peak intensity. So it's real fast and it peaks real high. So, if you were looking at an anxiety attack, it might look like this, or, like this, and a panic attack is whoop, whoop. Okay. It occurs within minutes. It's discrete and it's usually much more severe. We do get people with really severe anxiety, but panic is different. Now, how do we assess for that? So far with adults, I have So far for adults, I have not used these diagnostic measures. They're also not on therapy notes, but if you wanted to have an assessment for panic, these would be two that are used. Okay. Um, the second one was interesting because it breaks it down into subscores for physical, cognitive, and social concerns. So if you think about panic, yeah, we're worried about our physical symptoms. We're worried about how we're thinking about our physical symptoms. And we're also worried about going out into the world. So, that might be useful to you. Now, the thing that I found more useful is the scared assessment for kids. That has a piece of it that, measures panic or somatic symptoms. And as long as you've got the kid taking the scared assessment, I think you have an accurate measure. Sometimes the parents will give you an accurate measure, but they don't always know everything that the kids are feeling, or they might exaggerate things. So, yeah. So I found that very useful for kids. What are our goals? Well, we want to decrease the frequency and severity of the panic symptoms, so the panic attacks, the physical symptoms. We want to decrease the fear reaction to the physical symptoms. We also want to break this cycle of anxiety about anxiety. I don't know if you all have heard the term second fear. That's a good term to know. It comes up in anxiety treatment, and I have found it a useful term to use with clients. It's literally fearing your fear. Okay. Um, so like agoraphobia is a good example of this. People fear that they're going to panic in a crowded place, right? Or an enclosed space or public transit, standing in line, whatever. This fear of the physical sensations also comes up in health anxiety. So I've seen co-occurring panic and health anxiety. It's all of this is second fear. And while we're on the topic of health anxiety, a concept I borrowed from the treatment of health anxiety, and I use it for panic treatment, is the idea that our bodies are noisy. Okay. For health anxiety, well, your body's making noise. It's reacting to exercise or being old or having the flu or whatever. That doesn't mean that it's harmful. It's sort of like if your child or niece or nephew is crying, well, yeah, I mean, they're sad, but they're not necessarily hurt, right? So sometimes our bodies make noise. Okay. So we want to break that cycle of anxiety about anxiety. And then, as we so often do in anxiety treatment, we want to increase their ability to down-regulate the physical stuff and for that matter, the mental, the thinking, and calm themselves down before the panic completely takes over. Okay. They'll ride through it a lot faster if they have that skill. Okay, so that's our goals. Treatment elements. Psychoeducation is huge. Okay, it's a revelation to most of our clients how this actually works. They think they're broken, and really it's just their amygdala being too conscientious. Okay. We want to teach them about the panic cycle. We'll see that in a minute. It looks very much like a cognitive triangle with a few tweaks. Thinking skills. How do you want to think about your panic? That's going to make all the difference. Identifying and targeting symptoms. So what are your physical panic symptoms? And that's important if we want to do interoceptive exposures. Interoceptive exposures being things we have them do to mimic panic symptoms that they might be experiencing, and therefore get them to habituate to those symptoms and no longer fear them so much. Relaxation techniques is also something we teach when we're treating panic. This last thing I have put in there, it's just something for all of us to know about. I have never had a client use it myself, and I've been here close to 4 years, is the FreeSpira. Usually I've been able to help people with their panic without needing to do that, but we'll talk a little bit about that so you know what it is. Okay, so one thing I want to say is pretty much everything you need to treat somebody for panic is in this book. As you can see, mine is very well, marked up and well thumbed. I recommend this book to adult clients regularly. I know it says Panic Workbook for Teens, but you know, what I tell them is I say, the language is nice and simple. It's an easy read. The anecdotes, since they're teenage anecdotes, they're very unthreatening anecdotes to adults. So, people are happy to read this book. And they can get through it quickly. And a lot of them have found it very helpful. And I found it very helpful learning how to treat this. So what do I teach people about panic? Panic is your body thinking there's a threat, even when your mind doesn't think there's a threat. Like I'm driving along on the road and all of a sudden I get these weird symptoms. We're talking about unexplained panic attacks, and that's actually what panic disorder is about the unexplained ones. So once you figure out that, okay, it's physical symptoms, right? Your body thinks there's a threat and it sends out this rush of physical symptoms. Why does it do that? Well, if you look at the actual individual physical symptoms, each of them has an evolutionary reason to be, okay? It revs us up, it keeps us safe if a bear was attacking or we were in some emergency situation, okay? Another thing to learn, and this goes to sort of the health anxiety, or am I broken? Am I having a heart attack? When we have panic symptoms, our body is built to handle it, okay? The things that our body does are things we're meant to survive, okay? Another interesting thing we can tell them, if you have physical symptoms of excitement, well, they kind of look like physical symptoms of panic. I mean, the fast beating heart is a great example of that. Panic is time limited. They need to know that. Okay. And then what is panic disorder? Panic disorder is your fear of having a panic attack and being unable to cope with it. So how about we teach you how to cope with a panic attack, right? That's going to kind of disarm it, right? Take the fear away. So that's the psychoeducation. The panic cycle, as I was telling you. So instead of thoughts, feelings, and behaviors, it's thoughts, body sensations, and arguably, emotions related to the body sensations, and then behaviors. So what does that look like? Well, the body sensations might be dizzy, lightheaded, heart pounding, hands sweating, all of the usual. The thoughts are, I'm not okay. People will judge me. I will freak out. These are things I've heard from people experiencing panic. And then the behaviors, I won't go because I might panic. That's really, I'm going to avoid the situation because I might panic. So that's a good way for them to see how this all fits together, right? Because like the cognitive triangle, it's sort of a self-reinforcing thing. The more you have of one, the more you're going to have of another. It all like can spiral up. So we want to see if we can get them to spiral down. Okay. So thinking skills. What do you think of your panic? Do you, are you think it's a dangerous sort of thing? Well, maybe you want to think differently about it. Is it a competitor? Is it a challenge to overcome? Is it a handicap? Is it something to be ashamed of? Is it a big, scary thing? Is it a barrier? We want you to start thinking differently about your panic. And part of that process is it danger or is it a false alarm? I love to use the toaster and smoke alarm metaphor, right? So, if you're in your kitchen and the smoke alarm goes off and you're running the toaster at the same time, are you going to call the fire department? Well, no. You're going to fan the smoke alarm and wait for the smoke to clear. And it's the same thing with panic, right? But our body and sometimes our mind can think that we need to call the fire department. Um, Catastrophic thinking, we want them to get to more neutral or realistic thinking. I never say more positive thinking. People are suspicious of that word positive. More neutral or realistic thinking is more believable to a lot of people who are scared. Um, Panic, this is a good metaphor. Panic is an unwanted guest. I really don't want panic to be here. But you know what? They came with, I'm gonna go to the party anyway. Uh, you know, Mantras or mottos can help people a whole lot. I've had people come up with some really good ones, but two very common ones. This is distress, not danger, which I'm sure you all have used in your anxiety treatment. Uh, Panic is not the boss of me. Okay, so kind of making it into something separate from yourself is always a good move if you want to separate from something. Um, okay, negative self-talk. People really get down on themselves for having panic. They think they're broken. And, compassion is going to really help to talk to yourself gently and say, all right, yeah, I know your body's doing this and it feels really bad, but we'll get through it, instead of saying, what's wrong with me? It helps to do it that way. Uh, you know, Again, this can be a question. In addition to being a mantra, it can be a question. All right, am I experiencing distress or am I experiencing danger? Is this uncomfortable or is this dangerous? They're not the same, okay? And it's easy to fall into that trap of just because it doesn't feel good, it's really harmful. Okay. So, all right. So I kind of lumped these two together because they really do go together, and we get to do something as a group here. Um, so for a lot of clients, if they have easily identifiable symptoms that they can easily mimic through an interoceptive exposure, that's going to be helpful to them. Not all panic clients have this, or we don't always approach it that way, but very often that is what will help. So what are your physical symptoms? You figure out what those are. How distressing is each one? 0 to 10. Does the intensity vary, depending on the symptom or depending on just find out as much as you can about their symptoms. All right, so once you know that, how do we recreate that symptom so you can do an exposure to it? Okay. A good example that I use a fair amount is I get people to spin if dizziness is their symptom. That one's really easy, and people are usually pretty willing to do that. And then it's like any other exposure. I'm sure you all have been doing ERP since the first week you had clients. You're going to practice the exposure repeatedly until the distress level goes down. And we're telling them, hey, what you're doing here is you're retraining your brain. You do it until your brain gets bored with it. So, and I'll give you my very my 30-second explanation of how exposure works. Panic starts in the amygdala, the stupid part of our brain. Stupid, but it wants to keep us safe. So if this part, the smart part of the brain, the prefrontal cortex, fears the physical symptoms, it's telling this part, the amygdala, hey, thanks for the useful information. Well, the amygdala says, all right, I'll give you more useful information, okay? And this keeps happening. By doing exposure, we reduce that process. The brain starts saying, you know what, this is a nothing. Don't even pay attention to this. And eventually the amygdala catches on and says, all right, you know what, I'll pay attention to something else. Or I'll just chill out and not pay attention to so many other things. So I'm gonna now try to launch the video of Dr. Kissen doing the overbreathing interoceptive exposure, and we're all going to do it together, okay? And, I haven't had a lot of clients who have had the exact symptoms that this exposure mimics, but I think even if you didn't have these exact symptoms, this would be a useful exposure because what it shows you is it shows you you can simulate your body doing something weird and move through it pretty quickly.
Aaron's going to lead us and we'll
can you time me for 40 seconds?
40 seconds, you bet.
Okay, all right. So everybody ready? Okay.
And does everybody know what it is that you're doing? So Merritt, maybe
We're
just a brief and fully, like you should be hearing it. I've done this. It brings on incredible sensations.
It's gonna feel funny, and that's okay. You can survive this. Okay. All right. So 1, 2, 3, go.
Ten more seconds. 2, 1. No joke, right?
Yeah, I mean, my whole face feels cold. Haven't done that in a while.
How do you guys feel?
Everybody okay? Yeah, I don't like it, but it's okay.
It gets you there.
Yeah.
Okay, talk us through it now, Merritt.
Okay.
Now that
yeah. So, okay. Oh, I'm sorry about the headache. Hopefully that'll go away real quickly. Throat getting dry. Dog is a paid actor. Dizzy. Yeah, I got dizzy. My face got cold. Dry throat. Hot would also be a thing. You know, that kind of rush of blood to the head or subtraction of blood from the head. Yeah. So you know, you can imagine somebody who has panic, even heart beating fast. Oh, okay. Yeah. Feeling your throat closing. Okay. So everybody's got a different reaction to this. So, you know, maybe it is useful, even if your thing is not, what I can't even remember what it's originally intended to do. I guess that kind of weird head feelings that people get from panic.
I think I got all of it. So interesting that some people feel it differently than others.
Yeah, it's good to know that different people are going to feel different ways, but everybody kind of felt crummy. Okay. And that's what you know, sad to say, that's what you want. All right. So I got to share this again. Give me a second.
Brittany had asked if it's 40 seconds or 30 seconds. I know Dr. Kissen does this for a minute. So I have to get back to you on that answer. I don't know if Alexis
40 was 40 plenty for me. Yeah. And I don't know, was there anybody who didn't get symptoms after 40 seconds? Big silence. Okay, 40 seconds is enough. Okay, good to know. So now if you hadn't done it before, you did it now, and thank you for being brave, because that's what we're asking our clients to do. Okay, so relaxation. Moving on to other things that we're treating. Yes, double check if your client has medical conditions that would interfere, and usually they would speak up if they did. But yeah, you should ask. What does panic feel like in your body other than the panic symptoms? So, you know, if they're getting dizzy, you know, and they're also getting short of breath, you might want to work on breathing. So what does their panic feel like? Observing panic come and go. So putting a SUD scaling on it, that can be a very useful thing to have them do, is monitor their own panic attacks. Okay, so it starts out with distress of 3, peaks at distress of 8, 2 minutes have gone by, 3 more minutes go by, and distress is back down to 2. That can be helpful, okay, just so that they see how quickly it moves, all right, or that it does move. Another technique for any technique for relaxation, really, but 3-3 grounding can be good, you know, focusing outside of yourself rather than on your physical sensations. Breathing is a good thing to do. It is, you know, to just calm your body down, either if you think you're having panic or when you are having panic. So diaphragmatic breathing can be good, which is
kind of literally the opposite of what we were just doing. You're slowing it down. But whatever kind of breathing exercise they like to do, if they would rather do box breathing or star breathing or 4-7-8, that's fine. Any breathing that exhales longer than it inhales is going to engage the vagus nerve and calm us down. So, yeah, so it gets the rest and digest system. Is it parasympathetic? Yeah, parasympathetic. Sympathetic is the one that revs us up. Parasympathetic is the one that brings us down. So, yes. Okay, good. Diaphragmatic breathing. Yeah, that's what I do when I need to calm down, and I can do it invisibly at this point. So, yeah. Okay, next slide. This is FreeSpira. This would be, I think, for somebody who has very severe panic symptoms, who responds or reacts kind of badly to interoceptive exposures, and who seems to, it seems to be breathing related, their panic. And what this it's a device. It's a device and software. It's like, you can see he's got a little gadget there, and he's got a cannula that's connected to it that's monitoring his breathing. And what it does is it teaches you how to pace your breathing in a way that balances your carbon dioxide levels, and that in turn can help some people who have panic that doesn't respond to what we usually do with them. The downside of this is it costs $2,000 and insurance doesn't cover it. Maybe that's changed. I don't know, but it hasn't. Okay. So if they want to do this, or you want to have them investigate it, you can get the information you need on this from the staff manual. And basically what we do is we refer them to the company that provides this. Okay. And it goes from there. All right, so case example. So this was Marty, 37-year-old male, married. His wife was expecting a baby. He was an executive on the very fast track. He was very happy about that, but also, had a lot of anxiety around, doing his best at work. So when I first started working with Marty, he presented with anxiety, insomnia, rumination. We got him to a better place with that. And since he was a really busy guy, he decided, you know what, I'm going to terminate treatment for now. Well, he came back some months later because he had an incident where he went to the ER. It was over the Christmas holidays, of all things. He's with his family, having a great time, ends up in the ER because he thought he was having a heart attack. And they said, you know what, Marty, it's a panic attack. So, and that led to him, other parts of this were him being afraid of, like blanking out during giving presentations, to the C-suite people, which he had to do sometimes. So, and he started to also be a little bit afraid of air travel. So, treatment, psychoed on panic symptoms, it's your body preparing for danger. We read the book together. He was one of the first adult clients I tried the book out on, and he loved it. It was great. We talked a lot about the panic cycle. We talked a lot about how his particular panic worked. Okay. We did use the SUD scaling. He got pretty adept at, especially on the airplane. He could kind of use that as almost a, I don't know, distraction from panic. If you're outside of yourself timing your panic cycle, well, there's a certain part of you that isn't consumed by it, right? Okay, what else did we do? Okay, so the symptoms got worse at first, and he did start fearing, am I going to have another panic attack? But he was he was a tenacious guy, so he really kept at it. Some people might need more encouragement. He started to, like I said, experience some agoraphobia symptoms. So then we shifted to exposures to getting out of the house. He also benefited from mindfully attending to panic. So that's that I am having the thought that I'm having a panic attack. his mantra was "This too shall pass." He liked that one. It took him a while before he was able to believe this is uncomfortable and not dangerous, but he did get there. So, and his treatment went relatively quickly. So, that was a success, and I haven't seen him since. So, I think he would have come back if he had problems because we had a good rapport. So my proposition at this point for what we should do next is for you guys to pair off and do a role play of being client and therapist. The therapist doing psychoed on panic for the client, and I've got the slide here if you want to do a quick screenshot of it so you have it. And I guess Lisa, will you put them in
Absolutely.
dyads and give
Yeah,
them
we
what,
can.
5 minutes, maybe? I don't know.
Yeah, we can give 5-7 minutes. I want
5
to
or
pause
7
for a minute.
minutes?
Merritt, thank you so much so far for this presentation. It's interesting also that Merritt pointed out kind of the agoraphobia, condition that goes a lot with panic. We had a group once that we had, I think it might still be going on with panic and agoraphobia together, since they really are conditions that kind of go together. Fear of flying is coming up for me. So many of the conditions that we talk about separately from panic are very similar, as we see across many of our conditions that we treat them very similarly. So Merritt, thank you for bringing that up.
Mhm.
Pausing quickly, does anyone have any questions before we go to breakout groups that we can also discuss afterwards? Any thoughts that have come up for anybody? I had to do some of my own 3x3 and some breathing after that panic exposure. So I was kind of in my own mind doing some breathing after that to bring myself down. Anybody have any feedback or questions? Yeah, Joey.
I'm curious about clients that are triggered, like their panic is triggered by either the sound or attention towards their breathing. Because I've always found that to be kind of a challenge. I guess I've gone under the notion of why don't we just keep breathing until we desensitize ourselves to it? But any tips on that?
Yeah, that's a hard one because I do know people who have gotten, I've had clients who have gotten weirdly focused on their physical, what would you call it, autonomic functions, right? I had a guy who developed a fear of swallowing. Am I doing it right? Yeah. That ends up being, boy, I don't know how you do it for breathing. What we did with him for swallowing was to have him eat different kinds of foods. He got to the point where he was afraid of eating different kinds of foods, and we made him an exposure hierarchy, and he gradually ate more and more difficult foods that he was afraid of eating. Okay. Does anybody else know what you would do for somebody who was afraid of breathing or got hyper focused on breathing? Yes, Jessica.
Yeah,
You have any-
I go by Jess. Yeah, I have
Sorry.
a client who, no, you're good, you're good. I have a client who is very hyper focused on her breathing. She is also a panic client. We watched a video on just how breathing works, how our lungs work, kind of just very cut and dry scientific. Some of the exposures we've done is holding our breath together at for 5 seconds, and then doing deep breathing together. She's also very worried about her heart, oh my God, her heart rate. And so there was just some basic psychoeducation on, when your heart rate increases while you're doing activity, that's good. That's what it's supposed to do. That means you're working out. That means your heart's getting stronger. And so as a result, you're going to be breathing heavier. What was another thing we did? Those are the main ones that are coming to me right now.
And the thing about exercise would be a good exposure for that, right? Because you're forcing yourself to you're doing an activity that's going to tend to refocus you anyway, right? So if you're running outdoors, you need to be looking where you're going, not thinking about how you're breathing, right? And the other, yeah, it gets you breathing. It exposes you to the heart rate increase. And then you can monitor the heart rate coming back down when you're done. Right. So yeah, that sounds great. Thank you. I should have emphasized this more is there are explained panic attacks and unexplained panic attacks. And it's important to realize that you will get clients who have unexplained panic attacks. Explained ones are panic attacks that result from some like some outside factor that scares us, right? Like we're presenting and we have a panic attack. Okay. Unexplained panic attacks just happen out of nowhere. Okay. And technically in the DSM, you don't have panic disorder unless you're having unexplained panic attacks. But I still think that what we teach people about panic is useful in both contexts, whether they're explained or unexplained. So.
Yeah, I think I said this with BFRBs, but I find with panic and just the psycho-ed is so important. So if there's anything we really want to practice is rolling out how you speak about that, the psycho-ed, of just when people understand it's not a heart attack, it's safe, you're going to be okay. I think that is just such a huge part of treatment. And so practicing that, I think, is also just as important as practicing the exposures. Merritt, if you agree or...
I totally agree. I spend most of my time and you know, doing psycho-ed and psycho-ed, you kind of need it before you do the exposures because we have to teach them that it's safe to sit there and pant with us, you know, before we do it. So